Welcome to This Explainer. If you're dealing with veterinary emergencies, you already know the golden rule. Time is literally tissue. Today, we're diving into Point-of-Care Ultrasound, or POCUS. It is the ultimate visual tool for rapid, life-saving assessments in crashing patients. We're going to break down how to use it effectively, efficiently, and with total confidence so you can save those lives.
All right, before we even pick up a probe, let's get on the same page about what POCUS actually is, and honestly what it isn't. We're not doing a 45-minute comprehensive specialist scan here. No way. POCUS is all about answering immediate, buy-or-any, yes or no questions, usually under 10 minutes. Does the patient have free abdominal fluid? Yes or no. Is there a pneumothorax? It's done right there, patient side, to help you make those split-second clinical decisions when a patient is actively crashing.
So here's our quick roadmap for today. We'll start with the core principles, then hit patient prep and technique. After that, we'll map out the 5 abdominal POCUS windows, slide up to the pleural space and lungs, and finally demystify those tricky ultrasound artifacts.
Kicking things off as Section 1, the core principles of POCUS.
This circular framework is kind of like a mental checklist, adapting perfectly to whatever walks through your clinic doors. We basically have 4 main applications. If your patient is unstable, you jump straight to triage POCUS, grabbing minimal windows to hunt down life-threatening issues fast. Once they're stabilized, we transition to serial POCUS to monitor how well our therapies are working. Now, if the patient is stable from the get-go, systemic POCUS acts as a great multi-organ screen. And of course, there's interventional POCUS, which is an absolute game-changer for safely guiding needles during procedures like thoracocentesis.
Moving right along to Section 2, patient prep and technique.
Look, in an emergency, minimizing stress is absolutely vital. Step 1, position the patient for their comfort, not yours. Often, right sternal or lateral recumbency is best. Step 2, put down the clippers. Seriously, don't clip. Just part the fur with alcohol to act as your coupling agent. It saves precious time. And Step 3, grab your designated portable ultrasound. For most of our small animal patients, a 5 to 8 megahertz microconvex portable probe is going to be your absolute best friend.
Okay, Section 3, abdominal POCUS and the 5 windows.
So, when we're hunting for free fluid or air in the abdomen, there are 5 key windows we have to hit. It's really a highly choreographed dance. We start right at the subxiphoid region, looking at the liver, heart, and caudal vena cava. Then slide back to the umbilical area for the spleen and intestines. After that, we check the right and left paralumbar windows to evaluate the kidneys and that retroperitoneal space. Finally, we finish up down in the pelvic region at the urinary bladder.
Now, putting that into practice, let's think about the physical execution of that subxiphoid window. You're going to angle the probe at about 45 degrees, literally tucking it right under the xiphoid process and pointing it toward the spine. Why? Because this specific maneuver lets the ultrasound beam slice right through the liver to visualize the heart, the diaphragm, and the pleural spaces. It's a fantastic view.
Let's slide up cranially into Section 4, pleural space and lungs.
When we shift our focus to the lungs, geography is everything. You've really got to know your boundaries, otherwise you might accidentally mistake a totally normal anatomical structure for a collapsed lung. There are 5 crucial borders to memorize here, including the hypaxial muscles dorsally and the sternal muscles ventrally. Locking in these defined borders ensures you stay right over the actual pleural space and don't confuse normal soft tissue for severe lung pathology.
Now check out the abdominal curtain sign. It looks incredibly dramatic on a screen, right? But it's actually a perfectly normal physiological artifact. It happens right at the caudal lung margin, where the air-filled lung overlies the diaphragm and the abdominal costophrenic recess. As the animal breathes in, the lung expands, and this highly reflective vertical curtain literally slides into view, blocking out the abdominal organs behind it. Spotting this curtain moving with each breath is exactly how you confidently locate the very edge of the lung.
Okay, I absolutely love this visual mnemonic, the bat sign. When you place your probe perpendicular to the ribs, the rounded, bright proximal surfaces of 2 adjacent ribs cast these dark shadows beneath them. Those are the bat's wings. Connecting them right in the middle is a bright white hyperechoic line, the body of the bat. That body is your pleural line. Finding this bat sign is crucial because it guarantees you're looking exactly at the lung surface rather than just staring at subcutaneous fat.
Once you've got that bat sign locked in, I want you to stare directly at the body of the bat. This is where the magic happens. You're looking for lung sliding, which some people call the glide sign. As the lungs inflate and deflate, the visceral pleura rubs against the parietal pleura, and it creates this awesome horizontal to and fro shimmering effect.
If you see that shimmer, boom! It confirms the pleura are touching, and you can confidently, immediately rule out a pleurotensis in that exact spot.
All right, final stretch. Section 5. Demystifying ultrasound artifacts.
This distinction right here is clinically vital. So in a healthy, air-filled lung, the ultrasound waves just bounce back and forth between the probe and the pleural line. This creates A-lines, these normal horizontal white lines that repeat down the screen at equal intervals. A-lines just mean air. But B-lines, those are a different story. B-lines are vertical, hyper-reflective lines that shoot all the way to the bottom of the screen like laser beams or lung rockets, completely obliterating the A-lines in their path. B-lines tell us there's increased fluid or tissue density right at the lung periphery. Now, context is everything when you spot those long rockets. Seeing 1 or 2 B-lines in a single window, honestly, that can be a perfectly normal finding in a healthy dog or cat, usually just representing normal interlobar septa. However, if you're finding multiple B-lines, or worse, seeing them merge into these wide coalescing bands of white, that should raise some immediate red flags for severe pathology like pulmonary edema or contusions.
So, bringing it all together, confirming a healthy lung surface really boils down to 2 incredibly straightforward criteria. Number 1, you absolutely must see that shimmering lung sliding, proving the lung is actually touching the chest wall. And number 2, there must be 3 or fewer B-lines present in that window. If both of those criteria are met, you can confidently check off that specific lung region as sonographically normal.
As we wrap up this explainer, I want to leave you with one pivotal question to ask yourself every single time you pick up that ultrasound probe. Are you trying to identify a specific etiology, or are you identifying a functional emergency? Remember, with POCUS, we aren't trying to diagnose the definitive microscopic disease. We are hunting for immediate, binary, functional emergencies, fluid, air, or severe dysfunction. If you master these basic visual artifacts and ask the right binary questions, you'll have the rapid answers you need to save that animal's life. So, what will you find on your next scan?